presenting. Okay.
We have a 58-year-old male from Thanjavur. His chief complaint was mild pain in the right flank for 1 month, increased frequency for 1 month, and dysuria for 1 month.
Priyanku, you want to ask anything, or shall we go on to
move on to the history of present illness?
Okay, fine.
The pain was in the right flank, was mild, insidious in onset. It was continuous, dull aching in nature, without any radiation or shifting or effort pain. There wasn't any aggravating or relieving factors. It was associated with mild fever without chills or rigor and increased frequency and dysuria. The patient also.
What do you mean by insidious in onset, Soumya?
So gradual.
See, progress is insidious. Onset
Yes.
cannot be insidious. Okay.
Yes, sir.
So you can say insidiously worsening, insidiously progressive. Right?
Yes. Yes, sir.
Onset, when it's set in, you've already said it set in some months ago.
Yes, sir.
Yeah. Right. What is a shifting pain?
So there was no radiation or referred pain or shifting of pain, sir.
Correct. What is shifting pain?
Shifting pain refers to the pain which originates at a particular site abdominal arrangement, but later on reduces at that site or disappears and shifts to a new site. So it's not originally filled on original sites. Actually.
So which urological condition causes shifting pain? I'm asking this to Soumya.
Okay.
So
this is what all of us have been telling you.
yes, sir.
Unnecessarily don't use terms which have a different meaning. Okay?
Yes, sir.
Radiation, yes. Referred pain, yes. But where does shifting occur in urological pain? Whoever is discussing the case gets into unnecessary trouble.
Yes, sir.
Take that off. Okay. Yeah, move on, Soumya.
Yes.
Yes, sir. History of loss of appetite and loss of weight, 8 kgs in 1 month, but it was not documented.
How do you know it's 8 kgs then?
So patient says that it's about 8 kilos.
So you put it as approximately 8 kilos. Okay.
Yes.
If you put an exact figure, that means we've documented it.
Yes, sir.
Yeah, Priyanku, all yours now.
Yes. Know a little bit more about the urinary symptoms here. Increased frequency and dysuria has been mentioned.
Okay, in all this set of symptoms, which do you think could be due to a more serious condition and which could be due to a less serious condition, or could all of them have equal importance? See, there are two sets. One is the pain and the second is the lower urinary symptoms. Right?
Yes.
So of these two, which do you think is the one we have to worry about most, which is more important?
Pain, sir.
You know why you have to make this up? Morning.
Morning, sir.
Morning.
See, when you ask questions from the person presenting, if you made up your mind which is important, then the less important can go to the background.
Okay.
Otherwise, you'll get half an hour lecture on lower urinary tract and you might find the pathology is somewhere in the upper urinary tract.
Okay, sir.
Okay. In this case, do you want to change your mind?
Yes, I'll be more interested regarding pain symptom of pain.
Hey, Priyanku, you have to speak a little louder. We can't hear you.
Yeah, yes. Am I audible now, right, sir?
Yeah, now you are.
Yeah. Yes, sir. In this case, I will be more interested in his first symptom, that is pain in the right flank. So, and other important symptom that is given is the loss of weight, which seems to
That's
be.
the question I asked you. Would you like to change your mind and give more importance
Yes,
to
sir.
the second set of symptoms? Supposing I say, no, he's got frequency dysuria. That's more important.
Ravi Chandra, that hypercalcemia patient.
Wait, stay there, yeah? Come on, why are you moving? Go back, please.
So the
You
second
don't
set
move
of
until Priyanku tells you to move or one of us tells you to move.
the second set is also important, sir, in view of the associated
No,
history.
Priyanku, I'm asking you, will you put the second set before the first? I say, no, flank pain and all that, that's all right. Doesn't matter, I'm more worried about his frequency and dysuria. Patient also is more worried about frequency and dysuria. Does that make the diagnosis different or more important? More important should be given to the lower tract symptoms?
Priyanku, I'll give you a hint.
Yes, sir.
Whenever you write an article in a paper or you're doing a thesis or something, you have a primary objective and then you have secondary objectives.
Yes, sir.
The primary objective here is what, in this case, the patient tells you first up. And then as a consequence of that first up, you then dwell on other associated features which might be in connection with that, will help you. It may be separate, it may be a totally secondary objective, like you're trying to assess sexual function after PFUDD, that's a secondary objective. Same here, you look at the primary problem what the patient had, and then see whether these associated features are linked to that in some way.
Yes, sir.
Answer Mohan that.
Yes, sir. My primary perspective would be to stick to the right flank pain, sir, and find out if there is any association of the
Fair
other
enough.
features.
Fair enough. Now, is there any additional symptom along with that lower urinary tract symptoms which will make you think that the problem might lie in the lower tract and not in the upper tract? Any symptom which would make you think, oh, maybe this is lower tract?
Sir, if there is an association, if it regarding any kind of symptoms, then the pathology might be primarily in the lower tract, sir.
No, you see, if there was hematuria in that set of symptoms,
yes,
then we wouldn't be so sure, because hematuria due to a lower tract lesion can also cause flank pain, or rather lower tract lesion can produce hematuria, also cause flank pain. Then there's a confusion. Here there is no hematuria.
Yes.
That is why you are considering flank pain as a more important set.
Primary. Okay, sir.
Okay.
Okay. Can move to the next slide, sir. So.
There's no history of hematuria, no history of nausea or vomiting. There is no history of any abdominal mass or bowel disturbance. There no history of bony pain, hemoptysis or breathlessness.
Samya, I would suggest one thing in the previous slide. If you're writing about lower urinary tract symptoms, it's useful to write whether both started together or one preceded the other. Okay? That will make it a little clearer. Yeah, let's go on.
Yes. Past history: patient had undergone right pyelolithotomy in 1985, left hernia repair in 87, PCNL in 2004, TURP in 2013. He received ATT for genitourinary tuberculosis in 2014. Following this, he had bilateral ureteric stricture and small capacity bladder and underwent ileal replacement of the right lower ureter and the left ureteric reimplantation, augmentation of ecocystoplasty plus appendectomy on 2nd of February 2015. And since then, he was on regular follow-up. He is also...
Just a minute, Soumya. Where was the hernia?
Sir, left side, sir.
Left side where?
So inguinal hernia.
Hernia can be from the diaphragm down to the femoral triangle.
Left inguinal hernia.
So put that as left inguinal hernia.
Yes.
Okay. I want a little discussion here.
I just want to point to the residents. The reason why Dr. Mohan is asking this is that you have to be very particular about what you write and what you say. That's his little idea of the expert. Be very exact. You see, is hernia, inguinal, spigelian, whatever else you want to do. It's inguinal hernia.
I want a little discussion here. If you have a patient like this is for the faculty, would it not be better for the candidate if this history was presented first and then what he has got now?
Yes, I would agree with that. This sounds like this has sneaked up on the person who is presenting it. So this should have been primarily told that this is what had happened earlier.
Because we didn't ask him. No, we didn't ask him for diagnosis. Otherwise, he would have been running all over the place with diagnosis to have this googly thrown at us. I mean, this is what I felt. Maybe Dr. Ganesh can also pitch in and tell us what he feels.
Well, if you look at it from the point of view of the symptomatology, the primary complaint is what somebody comes with, and then as a result of which these are all evaluated. So what we should do is actually in a patient like this or in a case like this, give the whole history rather than at each point. That means the faculty must know what this case is up front so that we can then say, okay, now we start the discussion at this point. This is the whole story. There's no harm in saying this is a gentleman who had all these operations and now he has come with this. That's another way of actually putting the whole story. But then it defeats the purpose of what we have been taught, that primary complaint is what the patient comes with. Chief complaint. And then all this chief complaint may or may not be related to any of this. All this history does help in a way, but it may not be related. That's the only thing.
It helps if the faculty knows in advance.
Yeah.
So they won't carry discussion on for 20 minutes on the first set.
Yes.
And then come to this. Okay. Let's move.
So just one point I'd like to make here for the residents who make discharge summaries. They tend to make the discharge summaries also in this order. There at least please put the history in its correct perspective, and then like this would come first if I have a discharge summary to be made.
Yeah, in chronological order.
Who's had an old patient of ours who's had undergone these procedures, and the last, if you had a review, you said that he was on regular follow-up, then mentioned when was the last review, and at that point in that review, he was all right. And now he has come with something. Okay.
I've added that slides at the end.
That's right, but when you present to somebody, then it's better that you say that as it's a major operation he's had. As a consequence of his operation, he's been on regular follow-up till December of 2019 when everything was all right. And now he has come with this. All right. You see, all the other operations which he's had, 1985, pulmonary, hernia, PCNL, all that, is really much older than what this is. This is a more serious operation. So,
Yes.
So Priyanka, on this slide, what more information would you like to have? Sir said inguinal hernia. Anything else you would like to know?
The site of PCNL is not mentioned. And I'd also like to know whether he received...
What do you think? Priyanka, what do you think? It's not mentioned, but what's your gut feeling? Which side?
It's right side, I think.
Why? Why are you choosing the right?
Sir, he had already had a right pyelolithotomy in
Very
1985.
good. Very good. Yes. Okay.
And regarding the information on ATT for GUTB, I'd just like to know whether he received complete course or for how many months he had received.
Yeah, he had completed his course.
Or for 6 months?
Yes.
No, see, this is another thing. Don't waste time on in the examination.
Okay, sir.
If they said ATT, assume that it is completed.
Okay, sir.
Otherwise, they would have put it as received incomplete treatment in 2014.
Okay, sir.
So you can proceed with the core of the case.
Okay, sir.
So eventually in this case it may not be relevant, but there is a line in between PCNL and ATT. TURP in a young patient. Would you like the histopathology report? Why was it done? What happened after that?
Yes.
He's now 58. So 8 years ago at 50 they've done
50, yes, sir.
this for completion. What was the histopathology?
Yeah, yes, sir. I would like to know. Yes.
It's very important because if you look at 2013 and then TB in 2014, you see, and TB means you would have definitely had some LUTs. So whether that TURP at that age is what Dr. Manish is talking about needs to be questioned. And whether it was a premature TURP, considering that he might have had a lot of LUTs as a result of the TB. And the TB was not diagnosed, must have been there in 2013 and TURP was there. This is how maybe the situation has unfolded.
If we were to take the counterpoint that maybe tuberculosis was introduced in 2014, the period is too short for all these complications to develop.
Yes, sir.
You get it? Which means this must have existed at the time of TURP. So we need to know what the histopathology of the TURP was.
Why is it necessary, Priyanku, to know the histopathology of the TURP? You didn't attend the master class last week?
Sir?
Priyanku,
Yes, sir.
you didn't attend the master class?
No, sir. I wasn't able to, sir.
Why?
Okay.
Then you would have. The reason is that you can get tuberculous prostatitis, right?
Yes, sir.
Situation where
That would have.
yeah, so that's the reason why sometimes histopathology is important. Of course, you can get a young man also having malignancy, but in a situation like this where the rest of the history has unfolded, you would like to know what the histopathology of the prostate was.
Yes.
The
Okay.
significance again there is if there was tuberculosis, ATT has been delayed for a year.
Yes.
You get it? That's quite a long gap after an invasive procedure. Any invasive procedure on a tuberculous organ is likely to cause dissemination.
Yes, sir.
Yeah, if there's nothing more to think or say, go on.
Yes.
Tell them to
Next.
proceed.
Patient had a loss of appetite and loss of weight, as it was mentioned earlier. There was increased thirst, bowel habit was normal, increased frequency and dysuria present. There's no history of smoking or tobacco consumption in any form, no history of alcohol consumption or any other substance abuse.
Thambi, the first 3 points must have come along with the history of presenting complaint.
Yes.
One has come,
Yes.
thirst has not figured, bowel habits have not figured. Okay,
Sir.
so they should figure in the history of presenting complaints because now he has to explain why the thirst. And that never figured as a symptom. Okay. Okay.
Priyanka, you don't have to put the things under personal history, bowel, bladder. If that is his main problem, let it, once it has come in the history of presenting illness, then it need not come again in personal history.
Okay. Yes, sir.
So yes, Priyanku, now you have to tell us what you're thinking could have happened. He's had a ileocecal cystoplasty.
Yes, sir.
He received ATT. Let's forget the PCNL and the stone for the time being.
Yes,
It was very long ago. And a year later, he's come with this. 6 years
Sir,
later, he's come with this.
Based on his presentation and the history that has been given so far, I would the two things come to my mind, sir. One is these symptoms could be resulting from complication of the major surgery he had.
No, you can't say some complication.
Augmentation.
Okay, not expected.
Yeah. It could be. Yes,
At this stage, you must be able to say what complications of that surgery can produce all these symptoms. That's the crux of the issue.
Yes.
What complications could they be?
So one of the long-term complication of the surgery he had is stricture or stenosis at the site of anastomosis, which could lead to back pressure changes and lead to presentation of flank pain in this patient.
Okay. Good. What else?
The other thing, based on the as a sequelae of the same surgical procedure, and the other complication that he can have is development of some urinary tract infections, which can also lead to the
development of
urinary tract infection, sir, which can lead to the presentation of he's having fever and having some lower tract symptoms like frequency and dysuria. That could be another perspective.
Okay. By and large, with such a long history,
yes,
you would not simplify it to urinary tract infection. Okay. There might be underlying UTI, but yes, what are the more important things which can cause these problems? You said one is stricture.
Yes.
Okay, by itself should not, but we'll accept it. Yeah, that's one complication.
Which kind of UTI do you think occurs because of ileal ureter replacement? Which would cause right flank pain?
Ascending UTI leading to pyelonephritis in this case.
Okay,
can lead to right flank pain.
You've given us two causes up to now: stricture, pyelonephritis.
Yes.
What else?
A third cause can be different, not related to the surgery, but it could be reappearance of.
No, you think surgery. See, he's had so many surgical procedures. Yes, we first concentrate on the bladder surgery and then think of any other surgical procedure which might have caused these problems.
You use the word back pressure changes. Why do you think back pressure changes in a patient who has had ileocystoplasty, ureteric replacement? Do you think the pressure will be transmitted across to the kidney to cause upper tract renal function deterioration or something else?
Sir, due to stenosis or stricture at the anastomotic site, there could be stasis of urine in the proximal part, which can gradually reflect in the kidney, sir, and lead to hydronephrosis or later on pyelonephrosis even. So that can lead to the presenting complaint of right flank pain along with fever.
Don't yet say hydronephrosis. Yeah. You think that there is an anastomotic stricture which has caused obstruction and is producing the flank pain, right?
Yeah.
Correct?
Yes, sir.
Don't hesitate, Priyanku. Nothing happens here.
Yes,
they bail you out of whatever trouble you get into.
Yes.
In that case, how do we explain the weight loss? How do we explain the increased thirst?
Yes, sir. Increased thirst could be due to his diabetic status, sir. He is a known case of diabetes, which may be uncontrolled. That could lead to the weight loss can also be because of that same thing, sir.
What else could it be?
As Mohan said, think surgically first.
Yes, sir.
Think surgically. He's had very major surgery. You also have said that he's a diabetic.
Yes, sir.
Could some of the complaints be related to the effects of the surgery, apart from this stricture and all the other things that we're talking about? Some other things can also be. Severe weight loss, increased frequency, dysuria. Basically, we want to
So
know
the electrolyte imbalances that can happen from the following the augmentation surgery where a bowel segment has been used. This can lead to different electrolyte imbalances or complications from
Priyanka,
electrolyte
this is where
imbalances.
you're
So that
getting
could
into
also lead
trouble.
to
Not electrolyte imbalance. Bowel segment augmentation can cause polyuria.
yes.
Correct? That can cause
Yes,
a
sir.
whole lot of other things. But he could be having polyuria, which he is not recognized, and that's the reason for his thirst. Don't you advise people who had bowel
Yes.
replacement or conduits to watch, and if they feel thirsty, drink more water?
Yes.
Okay.
Because you have used ileal segment, specify what electrolyte imbalance you are looking for.
Here, in ileum segment is used, sir. It results in hypokalemia, sir. Hypokalemia and hyperchloremia, leading to metabolic acidosis.
Okay,
And,
so is there any other cause which could explain all this? Or should we proceed?
could be increased frequency.
one more thing I have in my
Priyanko, could the increased
yes, sir.
frequency, Priyanko, could the increased frequency be due to a voiding problem because he had no augmentation? You think he's emptying his bladder properly?
Yeah, it can be, sir, because of that.
So that's why you have to think of every possibility. You can't just leave it and say electrolyte imbalance or something else first. You have to
Yes.
look at all the of bowel segment in this patient. As a result of that, he could have his diabetes. Could he have medical renal disease as a result of diabetes?
Yes.
Adding to that is the augmentation, which could produce further deterioration in renal reserve. As a consequence of that, he can get increased thirst because he's got renal failure. He can have increased frequency, or he can have increased frequency because he's not emptying his bladder. And he's got residual urine inside that's getting infected. And he's getting pain in the loin because he's got pyelonephritis and infection. So, you have to think of all these possibilities. There are lots of things in this case. It's not just a straightforward one. And you are expected to discuss every aspect of it and keep talking about it. It's not just one diagnosis here.
Yes.
So if Priyanka,
one more differential I have in my yes.
Go ahead.
Sir, and finally, sir, other than these things, I would have one more differential, that is reactivation of GOTB in this case, sir. That could also lead to the presenting symptoms, flank pain, and lower tract symptoms, sir.
Okay. So, Priyanka, what I was going to say was that if you have a difficult situation like this, try and follow some sort of a template. If you're doing that, the examiner will know. So here, if you would tell us the renal causes, then go down to the ureteric causes, then to the bladder, then to the prostate, and then systemic causes, diabetes, like sir said. So if you think and speak in that order, then you won't get interrupted. You will be able to put your point across easier.
See, even the examiner may not be able to explain this, but if you can show that you are thinking logically and systematically, that is to your credit more than the exact diagnosis. After all,
Yes.
exams are about that.
Yes.
So can you put it in that order again? What could be renal causes of this problem, urinary causes, anastomotic causes, bladder causes, and prostatic causes?
Yes. Renal causes in this case would be
Not would be, could be.
Yeah, could be pyelonephritis. With 1 month history would be acute pyelonephritis. Then then the next cause will be distal ureteric stricture or stricture anastomotic site leading to.
Can there be a stone in the kidney?
Yes, sir. It can be a stone in the kidney also, sir. Because stone is, this patient already had a history of stone disease. From that side also, he has got more propensity for recurrent stone disease. And the other thing is the augmentation or surgery.
No, wait. Stay with the kidney.
Yes.
Could he have something else in the kidney which is giving him pain, which is also giving him loss of weight?
Yes, sir. It could be renal mass, sir. Because
No. Renal mass is not a diagnosis. It's a finding. We've repeatedly said this during our discussions here.
It could be some neoplastic lesion in the kidney.
What? Some neoplastic lesion?
Renal cell carcinoma.
See, he's had 2 stone episodes.
Yes.
So what malignancy is more likely to occur with stone disease? And there is no hematuria at all, which is a telltale sign.
What is that malignancy as a result of chronic irritation? Chronic irritation.
So squamous cell carcinoma.
Yeah.
So in that case,
hematuria. Hematuria is, one of those symptoms which is very unusual in squamous carcinoma. You usually have tissue bits coming out in the urine.
okay, so kidney, you have said it could be pyelonephritis, it could be recurrent stone disease, it might just be hydronephrosis, or it could be a squamous cell carcinoma due to long-standing stone disease.
Yes.
Fine, let's move down. Ureter. What type of ureter does he have now?
Lower part is the ileal ureter, sir. Ileal ureter.
What is his upper part, lower part?
Sir, replacement of lower ureter by ileal segment, sir. So lower ureter is the ileal ureter and upper.
If you had to do this surgery, what would you do? You have to do an ileal replacement because of multiple strictures. Would you replace the entire ureter or just the part of the ureter that was strictured?
In case of multiple strictures, sir, entire ureter will be replaced, sir.
All the multiple strictures are in the lower 1/3. They're all in the pelvic and maybe iliac ureter. Why do you want to replace the entire ureter? There must have been some reason why people were doing that, right? Anybody else? Will give Priyanku a little relief.
That ureter is already diseased by TB, sir. That invariably the TB is from the kidney to the ureter, sir. So that eventually will get stricturous.
No final years here?
Final years are not yet.
Karnakar and Nayan are not here?
Yeah, we are.
Sorry? Hey, then you guys must be answering here. It's important for you. Praveen will answer, Sampaji will answer, that's okay. But you are the guys who should take up these questions actively and answer, because maybe in a month's time you're going to be facing this. Yeah, Praveen, go on.
So they're hoping that it's like the 12th boards.
Praveen, go on, Praveen. You're giving some explanation.
I suggested that the USI president and secretary.
Sir, the entire ureter is already diseased, sir. The stricture may not have.
No, here you are finding the strictures only in the lower ureter. So I'll say leave the rest of the ureter alone, just replace the lower ureter.
And also the blood supply would be cut off, sir, from below.
Not cut off. See, when you to answer this, you must say that the progress of tuberculosis and its sequelae are long term. What appears normal today can become stricturous tomorrow, right? And of course, like you rightly put, in the course of dissection, much of the vasculature might have been compromised. That's the reason why people used to replace the entire length of ureter, not just one segment. Though I think recently people have reported appendix replacing just one segment and so on. Fancy stuff, but this used to be what we were taught and what we practiced.
Additionally, also, you must remember that there is a discrepancy in the luminal diameter between the ureter and the ileum. So you have to go to the point where it is maximally dilated, which matches. And you are replacing only half bit of the ureter with the ileum, then you have to tailor the ureter, the ileum, so that it doesn't become like a baggy shirt, it's just hanging around there. So if you want to exit, so that's the reason why you sometimes may have to replace the entire ureter with the ileum, and usually go to the point where it is maximally involved, dilated.
Okay, let's move on. Shall we?
Next slide. Yeah. This case is not really very straightforward, let me tell you.
Yeah, I know.
And I can also tell you finally what happened.
General examination. Patient was conscious, alert, cooperative, and oriented to time, place, and person. Blood pressure was 130/80. Pulse rate was 78 per minute. Performance status ECOG2. Pallor, cyanosis, clubbing, edema, dehydration, and cervical lymphadenopathy were absent.
Soumya, why 2?
Sir, he was able to perform his daily duties with difficulty.
You mean he had difficulty in activities of daily living?
Yes, sir.
That's the way you should put it. Not he was able to perform. That puts a positive spin on it. Okay, fine. Priyanka, you can ask them there if there's anything you find interesting. You have to comment on every slide or say pass.
Pass. The only positive finding here is the ECOG status. Then we can move to next slide, sir.
Midline scar and scar in the right lumbar region. Abdomen was soft. Mild tenderness in the right lumbar region. Right renal angle tenderness was present. There was no mass or lump palpable. Bowel sounds were heard. Per rectal examination was normal.
Priyanka, what is this renal angle?
So it is the angle where between the 12th rib and the erector spinae muscle, sir.
Erector
so
spinae.
That is the place where we take.
Erector spinae is very medial. It's next to the spine. And patient may not have a 12th rib. see, we all use this very often in our descriptions. Please read. Some cranky fellow like me will get you stuck on this. Okay. Yeah, your case, Priyanku.
Yes, sir. So he has got tenderness in the right lumbar region here, and renal angle tenderness. So that would also that would point to some underlying active renal pathology, sir. It could be due to renal. It could be due to pyelonephritis, or it could be due to stone disease. From these findings, sir.
Is there some finding which is missing, which you are interested in? There is a scar in the lumbar region, there is pain in the lumbar region.
You had a doubt about right or left inguinal hernia.
See, what is it in a long-standing scar can cause pain, especially in the lumbar region, because the incisions are pretty big. We cut through muscle.
Yes. Hernia.
Yeah, so that's something which is missing, isn't it?
Yes.
They're not telling you whether there's a hernia or not, and they're not telling you whether the scar is a stable scar or not. Okay.
Next slide. Sir.
Genitalia was normal, prepuce was retractable, meatus and glans were normal, both testes were normal.
Fine.
Okay.
Let's move. See, Soumya, when you write history, in general, if we don't expect any other system to be involved, but are doing a system review, we call it system review rather than go by CNS, RS, CVS, and so on. Okay, if there is something you suspect in one of these systems, then you mention the findings in that particular system. It saves time.
Yes, sir.
Okay, if you say CNS is normal, it will begin with higher mental function, sensation, proprioception, motor power, coordination, all of that.
Yes, sir.
So just a systemic review, normal. System review, normal. If the examiner is interested, he'll ask you what do you mean by that. Which system would you be interested, Priyanku, in this patient, in examining in particular in this patient? Abdomen, of course, you'll examine.
Yes. Examination of the spine, sir.
Think again. Something more common.
Chest respiratory system.
Yeah,
Here
you want to examine the respiratory system.
Yeah. Yes.
This is a history of TB.
TB.
Yeah, you want to see whether there are any pulmonary sequelae which were missed earlier.
Yes.
Okay. Yeah, let's move on to the interesting bits. Okay.
These are the investigation findings, sir. So
you must tell us which ones worry you. Or do all of them worry you?
so almost all are positive findings are here. He has hemoglobin of 9.7. That is his anemic.
Positive is one. Significant is something else.
Yes.
So are all these significant, not significant? Is there anything which is not significant to you?
No, sir.
All are significant.
Significant,
Okay.
sir.
Now we will focus on a couple of things and ask you why this could have happened. Let's leave the diabetes aside. It's
Yes.
not our problem.
Okay,
Why
sir.
does he have elevated calcium?
Sir, elevated calcium could be because of underlying malignancy, sir, renal cell carcinoma, and
Where is the renal cell carcinoma? No hematuria.
no hematuria.
Hey, you guys are all fixated on renal cell carcinoma.
And patient also has a history of use of bowel segment for bladder augmentation, sir.
Does that cause
So-
hypercalcemia?
Sir, short bowel,
How much will you use? You've used about 20 centimeters with the ureter. You might have used another 7-8 centimeters with the cecum.
okay. Patient may be having hyperparathyroidism also. So
Primary, secondary,
underlying
what
that
type?
could also be
Primary, secondary, what type?
yeah. We have it can be primary or it can be secondary.
No, it can be anything. It can also be tertiary.
He's got history of stone disease. He's got a creatinine which is elevated. So, Dr. Mohan's question needs to be answered thinking carefully.
Along with calcium, what other parameter would you have liked?
So parathyroid hormone.
No. We don't do parathormone for everybody. Something which would have been part of this panel. Maybe they've not included it because the lab routinely does it.
Phosphate, sir.
Yeah, phosphate. See, I brought this up because calcium often figures in several urological conditions. So you must know what is ionic calcium, what is corrected calcium or free calcium. You should know the relationship between calcium and phosphate, and you must know when this gets deranged, that is, in what conditions this gets deranged. And perhaps some examiner might ask you, what is the treatment for hypercalcemia?
Yes.
So this much all urology residents should know. Okay, not just for stone disease, wherever an abnormal result like this shows up, they're going to be asking you. So now do you think this is malignancy that he's got hypercalcemia?
Yes, sir. It can be, sir. Malignancy.
Therefore, the safe answer would be, I haven't ruled it out.
Yes, sir.
I haven't ruled it out. See, they'll say, yes, you're thinking about it. I haven't ruled, I need some more information. But right now, there are other reasons why this man's calcium could be also elevated.
Yes, sir.
Let's move on.
Sir, I would like to add this hypercalcemia is due to tuberculosis, sir.
There are many causes, Kamal. That's why I'm telling you, you read these up.
Okay, sir.
Okay, because I wouldn't be surprised if Dr. Prabhu put this as the next question for the next week's theory answer.
I think it's coming.
I know.
He
So,
formed it in his mind, maybe written it already.
the important thing here is this will spring at you in the OPD or clinic when you're seeing a patient and throw you off gear completely. So you must know this. The calcium different forms of calcium phosphate relationship, and finally the causes of hypercalciuria, calcemia, where you have to correlate the calcium level with the phosphate level.
The other thing we all miss in your history is what medication this patient is on. That never comes in the slides. So whether he's on calcium 3 times, 2 times, of course, what all the entire list of medications should be known when you have a patient with these kinds of problems.
Soumya,
Yes, sir.
that's for you.
Yes, sir.
And anybody else who's going to prepare for the next week. Okay, so now for us, everything else is explainable one way or the other. Fortunately, the potassium is normal. Why is the sodium 142? This figures more in nephrology, but maybe it's worth reading up out of curiosity, particularly if you're going to be doing cadaver organ transplantation. Effects of hypernatremia on different organ systems in the body. Okay, Priyanku, keep this in mind, look it up. So you have hypernatremia, you have hypercalcemia. The other things we know could be due to what we've already seen. ESR can be elevated.
Okay, sir.
Hemoglobin,
Yes.
glycated hemoglobin is high because of his diabetes. Creatinine because he's had so many problems and he also has diabetes.
Yes.
What we want to know here is what exactly is the cause of creatinine rise, if we can establish it, and can we do anything to bring the creatinine down? Okay.
Yes, sir.
Yeah, let's move on.
So, next,
The serum phosphorus was 3.5.
Very tricky guys you are, man. Generally, Coimbatore people are very straightforward. Okay.
The serum phosphorus was 3.5. Ionized calcium was 8.84. Parathormone was 7.7 and vitamin D3 was 13.4.
Why was parathormone done?
So rule out to any hormonal.
What were the indicators of primary hyperparathyroidism in this presentation?
So the calcium levels were high, sir.
Okay, does all hypercalcemia, is it due to hyperparathyroidism, or is hypercalcemia the only indication that the parathyroids are acting up?
yeah.
Okay, this is where, Soumya, I get your point, because this might be part of your lab training to do all this. But you must know when to do parathormone and when not to, because it's pretty expensive and occasionally can be misleading. Okay. Generally, the role for parathormone estimation is when there are features of generalized features or systemic features of hyperparathyroidism, either in terms of symptoms or in terms of calcification or in terms of bowel disturbance. Then we do this. And of course, we do this in children who have skeletal maldevelopment. Yeah, okay. Priyanku, carry on now.
So here,
This is the routine examination of urine, macroscopic straw color.
Hey, again, see, you're giving us a very difficult time, Soumya.
Yes, sir.
Put all this in the beginning. We have that, isn't it? Routine hemogram, followed by urine examination, and then followed by the more specialized tests like biochemistry, hormone assay, and so on.
Yes, sir.
Don't put it right at the end.
Yes, sir.
So, plenty of past cells are there in microscopic examination with RBCs, absence of bacteria, and other finding is albuminuria in these patients.
Just albuminuria, or do you want to add an adjective there? Do you want to comment
Macroscopic.
Not microscopic. Hey, albumin we don't see with the microscope. How do we look for urine albumin? How is albumin tested in urine now, and what was the traditional way of checking for albumin?
Watch that.
See, albumin is classified.
They used to teach us, no? In biochemistry, they used to teach us this.
Yeah, they had to do all this.
Albumin, they'll give a sample of urine and full of nephrotic color, they will give one sample and they'll say test for albumin. Then you add something inside and one nice curdy precipitate will come.
See, on urine examination.
The stick, no? Nowadays you put a stick.
Yeah.
Dipstick.
Have you heard of Esbach's albuminometer?
ESBACHS.
Clearly no. Okay, it's all right. The point I would like to make here is albumin in urine on examination is classified as trace, mild, moderate, severe. Okay, and if we find anything more than trace, then we have to do a time collection over a long period to see how much albumin is being excreted every day.
Yes, sir.
And nowadays, of course, because of the cumbersomeness of the test of 24-hour urine protein or albumin, everybody is now doing the protein creatinine ratio. It gives you a good index as to what is the excretion of albumin per day. It's important to know this. This fellow has got diabetes, his creatinine is around 3, he's had augmentation, so all the reasons for this sort of albumin.
Yes.
You got 3 plus or 4 plus albumin here, that means he's got a state of diabetes, possibly nephropathy.
So, urine ACR test is nowadays routine by most of the clinicians.
Yeah, you want to move on.
Yes.
Lots of interesting stuff coming up later.
Yes.
So let's move on.
Yes, sir.
Well, let's go to the imaging mode.
Yeah, we'll go to the imaging.
That's
Sure.
probably more.
Sure.
Yeah,
You think this patient could be having an infection, Priyanku?
Yes, sir.
You think he's got an infection?
Chest X-ray seems to be normal, sir.
No. On the basis of whatever you have got information, the history, would you say that this patient has an infection?
Yes, sir. He has a raised total count level, sir.
Between infection and malignancy, what's your bet? At the moment, is presenting complaint and all the history that is there.
Infection, sir.
Yes, okay, right.
Yeah.
So with that in view, what would you like to do? Investigate.
Yeah, imaging, sir.
Yes, go ahead. From the imaging.
Priyanku, I think sir is being very kind to you.
He wasn't like this in examinations, let me assure you.
You have to ask what investigation you want and that will be given to you. You cannot just say, I will do imaging.
Yes. I would like to have. I would like to do an ultrasonography, USG, KOB in this case. And
Priyanku,
yes.
Again here remember, he's had complex surgery on the lower urinary tract, upper urinary tract, everything.
Yes.
In this situation, ultrasound is not going to yield you much.
Yes, sir.
Especially if there is gas in the bowel segment, ultrasound will get horribly distorted.
Yeah.
So you must think of one imaging solution which will give you all the information you seek.
Yes, sir. I would prefer to do a CT urography, but since the creatinine is raised in this patient, so I will go for an MR urography, sir.
MR urography. Will that be satisfactory way of imaging the urinary tract? See, with MR urography, only the dilated portions get shown. If something is collapsed, if something is small, you can't see. So, even if there is renal failure, with adequate precaution and nephrology support, a contrast CT still offers the best information that you can get.
Okay.
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 So you can see whether there's anything correctable, maybe put in a PCN if there is hydronephrosis, maybe hydrate the patient because he's got polyuria, he's got polydipsia, and then they have these masalas which they give to reduce nephrotoxicity. And then take the help of nephrologist, dialysis standby, explain to the patient that you might need dialysis if the creatinine goes up further, and do a contrast CT.
Priyanka, won't contrast enhanced MRI be safer?
Asking me, asking Priyanku?
Yes. Priyanku, sir.
Priyanku, that's a trick question, right? That's a trick question.
See, for many places, we say if you can't do CT, do MRI. So, Dr. Manish is asking you, why not do a contrast MRI instead of CT?
Yes, sir. Contrast MRI would be safer, sir.
I think, man.
That's why I said it's a trick question.
Priyanka, you have seen these lab reports. Will you be debating about what imaging, or you will do something actively in this patient? Straight away you see a patient, you tell him to come tomorrow for this thing, or you are going to act immediately after you saw some of the reports?
Doing MRI with up to 3, isn't it? Creatinine.
Yeah.
EGFR was 22.
Yeah. EGFR is 20 here, very low.
And the toxicity of MR contrast increases with.
No, his EGFR is 22. No, this fellow.
Yeah.
So any GFR below 30, Priyanku, you can have nephrogenic sclerosing fibrosis, which is an irreversible condition which can cause mortality. Unlike contrast nephrotoxicity, which may be reversible and which can be managed with dialysis. So this is a contraindication for gadolinium to be given. Okay, now to answer, do you understand what Dr. Prabhu is trying to ask you?
Is there a medical emergency? Should the patient be immediately admitted, something done, and then all this imaging business can be attended to?
The counts are raised and the patient is having significant
hypercalcemia. Is there anything even more serious than counts?
Hypercalcemia.
Something which, it can cause sudden death.
Yeah, that has to be managed, sir, first.
Okay, that's why Dr. Prabhu asked you the question.
Yes, sir.
Let's move on to imaging.
So the imaging.
Mm-hmm. What imaging is this, Priyanku?
This is MR urography, sir.
It's an MRI. We don't know whether it's urography.
Oh, okay, sir.
No contact. Yeah, CT also.
See, you're seeing the biliary radicals and all that opacified.
Last year CT scan he had.
Let's go to the report.
Go to the report.
Yes.
No, skip all this, go to the report straight, please.
Then so, report gives dilated right collecting system with air pockets, which is suggestive of some foci of secondary infection or pyelonephritis.
Don't add all that. Say there is infection with a gas producing organism. Okay? Because you're
Yes.
seeing air. Yes or no?
Yes, sir.
Just say there is infection, dilatation with infection due to a gas producing organism.
Yes.
Okay.
The other part is that there is a mass lesion in the lower half
What
of the
is the
right.
second line? A third line.
Narrowings in a right pubes and some
Yeah.
levels.
So he's got a Puget stricture.
Puget strips.
Okay. Then
And mass lesion in the lower.
what is the nature of the mass lesion? Look at that.
Yes.
See, that description is important. You'll realize why as we go along.
Lesion shows heterogeneous configuration.
No.
Heterogeneous.
Right. Read from the first line of that paragraph.
Yes. Lower half of the right kidney shows lobulated, rounded, mass-like configuration.
Yeah. So what masses in the kidney produce lobulations? Keep this in mind. Let's move on to the rest of the description.
Yes, sir.
Is this sinus lipomatosis worrying you? Is that the cause of the dilated pelvis and ureter?
That is in the left side, sir, left kidney.
Correct. Does that worry you?
Not in this patient, sir.
Why not? There is dilated pelvis, there is dilated ureter. There is cortical thickening. Okay, move on.
Okay.
The last line.
The bladder shows augmentation changes with reimplantation of left ureter and connection towards right ileal ureter.
So what would your diagnosis be now? Okay, we'll give you a little rest. We have two smart guys going for the examination. Unless it's already over. Yeah, Karnakar, Nayan, one of you now take over and tell us. We've seen the description, you heard the description. We know all the investigations. What is your diagnosis?
Sir, it may be the chronic inflammatory lesion in the right kidney. Could be the tuberculosis or.
No, but why is it lobulated? See, inflammation, if it takes place, usually happens in the lumen, right? But here we've got an exophytic lobulated lesion. So we come back to the question, what mass lesions of the kidney are typically lobulated?
Sir, first is the renal cell carcinoma itself can produce lobulated mass.
Is it common to see lobulations in an RCC?
No, sir.
So that's how you have to take it. In which malignancy is it common? I'm sure you must have seen at least one or two during the last few years. Anybody else from Vednagam?
Sir, lymphoma can present with a lobulated mass, sir.
What else? Lymphomas are usually not exophytic.
Oncocytoma.
Oncocytoma.
What else? They're rare.
Angiomyolipoma can present with elaborated mass, sir.
What else? In this context, something else which might give us a diagnosis.
Squamous.
Oh, go look it up. I can tell you very easily, but you'll forget again. Go look up. Okay. I'm sure Dr. Ganesh, Dr. Manish, Prabhu, everybody is eager to tell you the answer. But I think you can look it up. Right. So we have a mass, we have narrow PUJ, and then right kidney also, left kidney also shows some dilatation, some cortical thickening, lipomatosis. What could be the cause of the lipomatosis?
Sir, repeated or recurrent infections.
Yeah, so it is an inflammatory response.
Yes, sir.
Okay, right. And now what do we do? Any other imaging available?
Any other imaging?
So imaging, sir, last year's imaging we have. So
Yes.
this particular admission, this was the last imaging. The MRI which we have.
Wait, show them that. Show them that. You got the answer there already for lobulated tumors.
Squamous metaplasia, the patients.
Okay. Then?
Can be nephrogenic adenoma.
Hey, come on here. Okay. I'll leave this at this because you're getting farther and farther away from how you should be thinking. Nephrogenic adenoma at this age in a patient who's had multiple surgeries, who's had tuberculosis, who's had treatment for tuberculosis, continues to have infection in the kidney, perhaps in the bladder and the opposite kidney also. Let's go to the next one. I think now we can ask Dr. Ganesh what they did.
Yeah, I think the thing that worried me was this guy when he came in last year. He was in 2019 December is when I saw him last, and he was quite well. His creatinine was all right, and everything was fine. He looked very sick when he came in, and I was under the impression that he's got an infection or he may be having a malignancy. Because he's had this bowel segment, we've seen malignancy happening. And then this hypercalcemia bit came about, and I thought, are we dealing with something that's, like one of these paraneoplastics types of things? And we just did an ultrasound in the hospital, the regular one, and we definitely saw a mass which could have been an infection with the high white cell count and the tenderness, etc. So I sent him off for a CT, and they said we would do this sort of an imaging. And because of the abscess, they actually aspirated. And I said, can we do a biopsy also at the same time? And they aspirated about 50 cc of pus from that. And that grew bacteria. We treated him with IV antibiotics. And the nephrologist came in with help for the hypercalcemia. And we gave him calcitonin and hydrated him, diuretic and steroid. To get that calcium down. It did come down quite nicely, and we gave him actually 2 weeks of IV antibiotics, and he improved dramatically. His creatinine improved, everything settled down, he started eating and all that. And we were concerned about this hypercalcemia, and we said that we must do some imaging. We actually did a we did a PET CT for him. And the PET CT, there was no suggestion of a lymphoma or a myeloma in this guy. So we said, let's do a PET CT because, we did a PET CT because we couldn't find any lymph nodes, and we thought maybe there's a lymphoma lurking somewhere or someone is the reason for this hypercalcemia. And there was a lesion there was an avid uptake in the region of the lung on the right side. And an HRCT was done, the CT of the lung was done. Yes, so that thing.
So images are
not available, but there was a lot of inflammatory response, avidity around the kidney, and there was an intense lesion in the region of the lung. And we said that this might require to be biopsied because, small cell carcinoma of the lung can also give rise to hypercalcemia. So we sent them for biopsy, and they said this is a very small lesion, a very tricky lesion. It's hitting right on the internal mammary artery, and we might hit it. Well, I said we need to do something about it. The patient responded very well to the antibiotic treatment, and all that settled nicely. But his calcium used to come down and go up again. You give him something, and it go up again. In the meantime, the second wave of COVID came in. And they're from Tanjavur, and they were very keen on getting back home. And because there was a window before the lockdown, actually, the government of Tamil Nadu said, you're going to lock down on Monday. So they decided that they'll go back home because he was much better. He was eating and all that. I was also concerned that he was having some esophageal candidiasis. So we got an upper GI endoscopy done, and that did not show anything wrong there. And so we did send him home in reasonably good health. And 10 days back, I got a call from his wife saying that he died. So I still don't know what the cause of the hypercalcemia is. We don't know what the lesion in the lung is. And all I know is that I strongly suspected, in fact, this squamous metaplasia was worrying me. Was it just was there actually a malignancy there? Because we know that squamous cell carcinoma of the penis can cause hypercalcemia. You see, so my feeling was this may be a malignancy in the kidney, and we didn't hit it because there was an abscess there was pus there, so there was a conundrum of stuff inside that right kidney, and so I still don't know what's wrong. This would have been a very good CPC ultimately, but we don't have the answer.
Guesswork here. One is it was a hypercalcemia that got him.
Yeah, I think so. I think that's.
And so perhaps he would have benefited with either denosumab or one of the bisphosphonates.
He was sent on the medication.
On denosumab.
On the medication, on steroid actually. He was on.
Steroid alone isn't enough. One of these, either a bisphosphonate or denosumab.
Just that renal failure was there, so denosumab was on the card, but it was very expensive.
Okay.
You got to put him on calcitonin also.
The second thing, for the lung lesion, an endobronchial biopsy could have been considered.
Well, that's why we sent him.
Yeah.
We sent him to the bigger hospital where they do have these facilities, and the pulmonology guys and the radiology guys sat together. The pulmonology guy was a little hesitant. He said, I may not be able to hit this lesion. Maybe a CT guided biopsy may be better. So that's when they said, okay. And two interventional radiologists actually saw him, and both of them were keen on sort of saying it's too small, it's sitting right on the internal mammary artery. We're a little worried about it.
The interventionists here say that if it is less than 2 centimeters, then they don't like to do a percutaneous biopsy.
Yeah, true. So, we were stuck, and at a point in time, I was actually thinking of exploring this guy, honestly, because I thought there was something lurking much more in that kidney. And that was a good kidney. The right kidney was the better kidney than the left, even from the start. And whatever has happened in in about a year, because 2019 December was when he last came in here. He was absolutely fine at that time. His voiding was good, everything was good. He didn't have any problem, residual urine, etc. So I think what killed him was probably hypercalemic cardiac arrhythmias, hypercalcemic cardiac arrhythmia, and not an infection here. So I don't know.
Priyanko, why did he have his thirst and polydipsia after seeing all this? Why do you think he had it? Or I'll ask Karnakar this question. Why Karnakar?
Yes, last.
The hypercalcemia also can cause increased.
Not also, it causes, it's one of the predominant symptoms in hypercalcemia.
Yes, sir.
Sure.
Can it be a can it be a malacoplakia, sir? Because it also
unless
can
we have
present
a
in.
proper histology,
Yes,
we
sir.
won't know. Yes, it can
Because
be.
it also presents with renal dysfunction, recurrent infection episodes can present
Agreed,
as a
agreed.
mass also. Yes, sir.
Agreed, it could be malacoplakia, but we would require histology for that.
They did do a biopsy here. They took quite a bit of samples. It's just that whatever came out was necrotic with all that pus.
Yeah, so it can be most of the time can be granulomatous reaction or inflammation. Sometimes in biopsy also.
Also possible.
That's the problem with a percutaneous biopsy. There's a lot of necrosis. It's difficult to hit. Like Dr. Ganesh said, if there was an opportunity and exploration could have been done safely, maybe we would have had more tissue, drained the abscess or whatever, and got a proper histology.
We sent him actually once more, and that thing had resolved significantly. There was no doubt about the fact that there was an infection here, and he responded brilliantly to IV antibiotics. Everything settled, his appetite improved, his counts came back, and he was doing good. And so there was an infection, no doubt, and I think there was probably maybe an infundibular narrowing as a result of TB. Uncontrolled sugars, he got an infection in that kidney and everything else. But lots of other issues here which cannot be explained. And the hypercalcemia probably is some malignancy. It's a paraneoplastic, I think. I think the best thing to know that what is the role of calcium in a patient with renal failure, what is the role of parathyroid hormone in renal failure, what happens, what is primary hyperparathyroidism, what is secondary, and what is tertiary. All these three things need to be known, okay?
And also, I think a little bit about the choice of imaging in patients with elevated creatinine.
We discussed this, I think. At some point.
We did.
We discussed that.
Any questions from anybody?
This is not a real so-called exam case, but it's a case which requires people to think and and answer. There's no right or wrong. As I said, we still don't know, but unfortunately,
if they land up in the OPD, it can be a real problem. You can't simply shoo these guys away to somebody else.
No, you can't.
So one needs to know what to do, how to go about diagnosing and treating these problems.